Hello, Dr. Shahidi, how are you?
Fine, thank you.
So we
Thank you
can
so much.
see you, we can hear you.
Okay, excellent then. So without further delay, I will start with the presentation. Just, I would like to thank the organizing committee to invite me to this wonderful meeting. I wish I would have been able to be present with you, but circumstances prevent me to be present in person. But I hope all of you are doing well and looking forward to seeing you soon, inshallah. So the question I was asked to treat this afternoon is: does left bundle branch pacing take over cardiac resynchronization therapy? I was about, to be honest, to change the title just to make instead of CRT biventricular pacing, because biventricular pacing is just one way of doing cardiac resynchronization therapy, and we have different ways to resynchronize the heart. So my talk will be focusing mainly on the comparison between left bundle branch pacing as compared to biventricular pacing. It has been now more than 20 years when we had the publication of the MASTIC trial regarding CRT, and over time, cardiac resynchronization therapy by biventricular pacing demonstrated really a lot of things: improvement of quality of life, decrease of mortality, positive reverse remodeling effect. And currently, biventricular pacing is a strongly established method regarding the treatment of a patient presenting with heart failure and electrical dysynchrony. However, biventricular pacing, despite its really simple technique, it's considered now as a simple technique. It's done transvenously, completely transvenously. However, it has some limitation, and some of them could be really significant limitation. The main limitation is that the technique is anatomy driven, so you need to have a good branch to be able to insert the LV lead. It's not all the time the case. And in more than 30% of cases, we are obtaining just a suboptimal position of the LV lead, leading to this group of patients qualified as a non-responder, which is roughly 30 to 40% currently. I would just like to add regarding the biventricular pacing. When we are pacing through the coronary sinus, it's epicardial activation, so it's not really physiological pacing. So what are the alternatives we have in case of failure to implant LV lead, or if the patient is non-responder to CRT and continue to have a left bundle branch block? So since few years, I would say 5 to 6 years, we started to have really an important interest regarding the conduction system pacing. And conduction, just to remind everyone, when we are talking about conduction system pacing, we are talking mainly about his pacing, because the story started with his pacing. But nowadays, since 4 to 5 years, we started investigating extensively the left bundle branch pacing. And I will mention the reason why we almost abandoned his bundle pacing. One thing we should keep in mind is when we are dealing with patient presenting with left bundle branch block and we are trying to synchronize by his pacing, the result will largely depend on the level of the block. Not all left bundle branch block are similar. So if we are not implanting our lead beyond the level of the block, we will not be able to resynchronize. And this is the reason why pacing the left bundle branch block, we are largely covering, we are largely beyond the level of the block. And this is the reason why it's really working very well. So more than 20 years of biventricular pacing, and all of a sudden in 2016, published in the American Heart Association journal, we have the first in human study using select secure lead. It's really a Nord lead. This lead is allowing us to cross here the septum, looking forward to touch the left bundle branch here. So the study was done in patients presenting with heart failure, And this is the finding of the study, narrowing of the QRS, which seen more importantly than when it's compared to right ventricular septal pacing or right ventricular apical pacing. And in terms of LV hemodynamics, judged on DPDT, you see here huge difference, significantly, statistically significant difference. So left ventricular, it was called at that time when we had this publication, it was called left ventricular septal pacing. And since that time, just 1 year after, we have the first case reports published in 2017, again regarding the feasibility and the outcome of the patient. So it was really demonstrated in this case reports that it's not really difficult to implant a lead into the left bundle branch. It was done in patients presenting with heart failure and electrical dysynchrony, mainly left bundle branch block, and over 1 year follow-up, the patients presented with a significant improvement in clinical outcome and significant improvement in echocardiographic parameters as well. And we did not stop seeing several studies comparing all the time the conduction system pacing versus biventricular pacing. And those of you who attended the HRS meeting in 2022, they saw certainly that in the late-breaking clinical trial session, at least 3 studies on the subject were presented. And all these studies had to answer this question: could left bundle branch block area pacing compete with biventricular pacing or even be better than biventricular pacing? And the reason why we have a really important interest regarding left bundle branch pacing, you can see here this patient who is presenting with typical left bundle branch block with wide QRS, largely exceeding 150 milliseconds. And when we did this, when we implanted here the lead within the septum, we are crossing the interventricular septum, reaching the left bundle branch, we are obtaining this aspect. And I think that everybody would agree that it's rare that with biventricular pacing we are obtaining such a narrow QRS here. It's not exceeding 100 milliseconds. The reason why it's easier anyway than the his pacing here in green color, you have the his pacing. The region is not really easy to attend. Over time, the threshold pacing will be very high, and it's really of significant concern in patient pacer dependent. The R wave is not stable over time. And again, it's really very narrow region. And if you compare here to the left bundle branch, the way we are doing this, we are just locating first the his. We are drawing a line here toward on the septum toward the apex, and whatever the region within 20 millimeter from the his until this region, you can cross the septum and touch the left bundle branch. So wide area where we can implant our lead. So the study, the studies were done. I will mention a few of them. Here, 40 patients with non-ischemic cardiomyopathy, randomized into 2 groups, left bundle branch pacing, biventricular pacing. And you can see here in terms of improvement of the ejection fraction, left bundle branch pacing is doing better than biventricular pacing. And whatever the parameter you consider, either left ventricular size, QRS duration, the ejection fraction, and so on, the left bundle branch pacing is doing better. And we had just recently published, just a few months back, this study where they compared the same thing, left bundle branch pacing versus biventricular pacing, and the endpoint was death or heart failure hospitalization, and they enrolled for this study more than almost 2,000 patients. And you can see, you can appreciate regarding this endpoint, it's significantly reduced with left bundle branch pacing. Another study, and they used here left bundle branch area pacing as initial strategy, and again, left bundle branch pacing demonstrates really good outcome as compared to biventricular pacing. I will mention this last study, which was published last year, just telling us that, again, whatever the parameter you are considering, either electrical synchrony, mechanical synchrony, or hemodynamic improvement, left bundle branch pacing is doing better than biventricular pacing. So what are the important point, and what are the benefits of left bundle branch pacing? We are obtaining low pacing threshold as compared, and it will remain stable over time. So it's really a huge difference as compared to his pacing. The sensing is quite excellent, and again, maintained over time. And we have really a wide zone where we can implant our lead. However, we do have some concerns and limitations, few of them, to be honest. I will not spend that much time on the septum damage. It's considered currently as a minor complication. The main issue is that we don't have yet the long-term outcome of the lead, since it's a young technology, so we do have just limited data. What to do with the lead at the time of extraction? So this is really a question mark. Who are the patients who will really get benefit from left bundle branch pacing? It has to be defined. And at the time being, we are still missing evidence for it. We have more evidence for biventricular pacing and his pacing. However, when we are looking, this is an example. Here again, a left bundle branch block, and the patient here is synchronized by left bundle branch pacing. I can tell you, when I'm showing this tracing to our fellows or even to some consultants, it's hard to convince them that this patient is paced rhythm. Most of them will answer that this is the intrinsic rhythm, but if you look carefully, you might see here the spike. So it's really amazing how we are obtaining really very narrow QRS. So just to answer the question, during the next coming years, for sure, we are expecting that cardiac resynchronization therapy will certainly change. The rate of failure to implant leads will significantly decrease over time. The therapy efficacy will improve, and everybody, the major centers are looking forward now to pace at the level of the conduction system, which is becoming a major, if not the major aspect of cardiac resynchronization therapy. And this is the reason why it's already incorporated into the last American guidelines, just published 3 weeks back. I will not, for the sake of time, I will not go into details of this busy slide, but I would, to finish my talk, just mimicking Churchill when he said, and we can consider it for CRT. This is my final slide. Now, for CRT, this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. With this, I would like to thank you very much.